Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner. I'm joined today by my very Mayflowery co-host, Dr. Jason Martin. He's a board-certified plastic and reconstructive surgeon. And it's turkey time. Cue the turkeys.
Yeah, cue the turkeys.
Cue the turkeys. Gobblers. It is mid-November, and Dr. Martin, Thanksgiving is my favorite holiday.
I love it. Yeah. I like the fact that you said I'm from the Mayflower. That would mean I'm aristocratic. I'm from originally Kentucky. I don't think I'm aristocratic at all. I think I'm like some Irish subfuge that came over in the 1700s. That's basically my lineage.
My people did come over on the Mayflower. Like I actually am able to be part of the Daughters of the American Revolution.
I'm sure you are.
If I wanted to, which I don't.
Nils and I are not.
Yeah. Yep. Someone actually asked on a recent episode where you were from, and I told them.
Yeah.
Louisville. Yeah. Or however you say it in the South.
You say, he's going to put it right here, Louisville.
Louisville.
So it's Loovil, Louisville.
Ville.
Yeah.
The other thing that Nils is going to flash up.
Sorry, go ahead.
Oh, here. The other thing Nils is going to flash up on the screen here is our social media handles. If you are not watching us, you can on YouTube at Jason Martin MD, and we are also at Beauty and the Surgeon podcast, wherever you find information. Sorry, I didn't mean to interrupt your multiple syllable thing.
No. Like the people in the South, they have a hard time with syllables. So they condense it down. It takes too many calories to say multiple syllables. So Louisville is 3 syllables. So Louisville. Actually, it's Loovul. That's probably more. Louisville.
So, yeah. Dr. Martin, what is your favorite Thanksgiving dish?
We go through this every year. So for me, it's always mashed potatoes, 3 parts butter, 1 part potato.
So here, controversial question: skins on or skins off?
Skins off.
Skins off. Okay. Nils?
Wow, that's a good one. I think I don't even remember what I answered last time because we haven't been doing traditional Thanksgiving. We've been
just because it's Thanksgiving doesn't mean you have to have a traditional Thanksgiving treat.
And one of the last years I did carnitas that were just amazing, and
like
just
pork carnitas.
Yes, pork shoulder. You know, they're crispy and tender, and just they go good on everything. And you make a huge plate of them, so it's like turkey because they're leftovers, and there's you eat it for like 4 days afterward, and that kind of like hit it. Like, I think we should do stuff like this more often. Maybe do the bird on Christmas or something. Yeah. But carnitas is gonna be but I'm from New Mexico, so that's not that crazy to have.
Yeah, it's a New Mexico Thanksgiving. I like it.
Yeah. How about you?
Oh, see, I love turkey, but I also love stuffing. So if I had to choose,
stuffing's my close second.
Yeah. Kind of for that same reason, because I like when the bread gets a little bit crunchy. You know, like the stuff, like I always go for the edge of the stuffing, right? Because it's where it got kind of crusty in the oven.
Yeah.
Crunchy and savory.
It kind of dried out.
It's a good.
And like, I like homemade stuffing better for sure.
Oh, yeah.
Yeah.
But even the store-bought crappy stuffing, I still like that too.
Good.
Yeah.
Oh,
it's like, I'll take any stuffing you want to give me on Thanksgiving. Yeah. I'm not going to complain.
Yeah. No, it's delicious. So, yeah. So if you're listening to this, it's just before Thanksgiving, so you have time to make all these delicious goodies.
And also plan your breast dog.
Your breast dog, which is actually, I totally buried the lead. That's what we're talking about. So this is part 2.
Part 2.
Even more you need to know about breast augmentation. If you did not listen to part 1, I highly recommend you go back and listen because we cover some extremely important things that you definitely need to know about breast augmentation, about the risks and complications and all that good stuff. But in part 2, this is where I almost said this to Dr. Martin before we started, like, you ready to talk? Because I feel like this is your part.
I know, but I like when you talk better. You have a melodic voice.
Well, I'll talk about sizing, but the first thing we're going to talk about is what is going to happen at your pre-op appointment. And then we're going to talk about surgery. So at your pre-op appointment, we're going to take your pictures. We're going to do implant sizing and selection, which we'll talk about more. Review your health history, get you some labs, talk about any medications you need to start or stop, discuss any pre-op labs or EKG, sign consents, get your payment, give your prescriptions, review the date and time of surgery, and answer any questions you may have. So a couple of important things that you should definitely know after your pre-op appointment. You should know where you will be taken after surgery. And we should know that too. So like we ask all of our patients, like, who's going to be picking you up, and are they taking you to your house? Are they taking you to their house? Just so we know where they are. What medications will you be prescribed or given? Will you have bandages? Will you have drains? When will they be removed? When can you shower? When can you drive? And when can you return to normal activities and exercises? And we will go over all of those things toward the end when we talk about recovery. But those are important things, like just on a basic level, like you should know those things. right?
Yeah.
Yeah. Those are important things to know. And for us, I mean, the reason I ask people where, like who's picking them up and where they're taking them is because if we have to call in prescriptions for somebody after surgery and they are not at their house, then the pharmacy information that they're giving me for like their prescriptions may not be accurate. So if I know they're going someplace else, I'll say like, do you know what pharmacy might be close to them? Or, you know, there's a reason we ask where you're going to be. So if your doctor's office asks you, they're not being stalkery. They just want to know where you are.
All right. So besides talking about the risk and benefits and signing the consents, let's talk about implant selection.
Well, no, we're going to talk about.
Oh, you have a whole slide.
We're going to. Yeah, I was going to say we don't need to jump on that because I have a whole slide on this.
Oh, let's go.
So if you are ready to talk about implant sizing, so I called this AKA Finding Your Goldilocks Implant.
Yeah, I think if you're going to watch anything from these episodes, this is it.
It really is. So there are many kinds of implants available. There's saline. There's this new structured saline that they say feels more lifelike. Silicone. Yes, these are gummy bear. That they feel more lifelike. Yeah, I mean, they're just kind of gimmicky, but they're fine. They're cool. Fine. Yeah, they're cool. The famed gummy bear implant or silicone implant. At this point in time, all silicone implants that most doctors are using, at least in the United States on the market, are going to be a cohesive gel implant.
Fifth generation silicone gel.
Which is just how much they're cross-linked. So how much they kind of stay to themselves. There's round, there's shaped, there's smooth, there's textured. I think the big thing with when you choosing your implants, you should talk to your doctor about what they recommend and why. You know, there are a lot of people who I think see it on social media like, oh, I want what is that one right now? The Impact is the one that's so buzzy. Okay, well, it's a brand new implant. I go back even to with the factory that burned down. Sientra. It was before it was Sientra. It was, yeah. You know, is that the implant that you'd want to put in your wife or your, like.
Right.
So there's probably a reason that your doctor uses the implants.
How to say we've worked together too long is us going through the history of implants and what's cool and what's not cool.
Yes, we've been through it all.
Like there's been so many, like this is the best thing ever. And then that's around for a year.
Yeah.
You know, basically there's three right now, two, almost a third, someone that's kind of gaining traction, but three main implant manufacturers in the United States. That's not a lot. And two of them, Mentor and Allergan, have been around for a long time.
Yes.
So, you know, and most of these implants have pretty similarly made, primarily because the FDA is not really cool with you bringing on like really strange new implants. It takes a lot of money to bring it to market, a lot of money to develop the IP. So I think people are just retreading from the old and changing it up a little bit. That's fine. Yeah. These implants are good. The cohesive gel implants, the fifth generation ones, definitely feel better than what we were using 10 years ago. They hold your shape better and they have more projection. We have more implant options now than we've ever had before. More projecting options, narrower, hyper projecting, a little less projecting. And that's really, I think it made it better for the surgeons themselves to kind of pick the right implant for you.
Yeah. Ultimately though, I think my point with this is that if there's a reason your surgeon uses a specific implant, even if you've heard about a different one on social media, like I'm not trying to downplay this, but let's be real. Like breast augmentation has one goal and it's to make your breast bigger for the most part. So
and have better contour, but
well, no, but it's making you have better contour by making your breast bigger.
Right.
So
you're adding volume. You're adding volume.
Yes.
By definition.
There's no secret sauce here. Like you're just making them bigger. So all implants that are FDA approved.
You're pulling the curtain back way too far there.
Are good.
Okay, let's just bring the curtain over a little bit.
It's more that I just don't want people to think that because this implant is new to the market that it's better. Or that it's best. It isn't. So,
I think, okay, I agree with it. I always agree with what you're saying. I think the better way to say it, at least to make me feel better, is that an implant is not going to make or break your case.
The brand is not. The size will.
The size selection will, and the base width, and Amy will talk about that, will in the projection you want will make the biggest difference. But the implant itself can be additive. I feel that way, but it's not a huge percentage of improvement.
Correct.
Over just the baseline of what we used 10 years ago.
No. And you could put, if the measurements were the same, you could put a different manufacturer's implant in either side, and you're not going to be able to tell the difference on the outside if the implants are the same measurements.
That's diabolical. That would be awesome. I don't think the FDA would be cool with that.
Why wouldn't they? That's the patient choice.
Yeah.
That's not an FDA issue. They're both FDA approved.
A patient would have to request it.
Exactly. That's what I mean.
Nils?
Yeah. Yeah.
Test it on me.
Yeah.
So, Nils, would you be able to insert the clip here of me talking about implant sizes, even though it is like a really old video and we've shown it on other episodes before?
And you look so young.
I do look young because it was a long time ago, but I'm going to talk specifically about the base width and the projection in this clip that you guys are going to watch.
Let's go to that clip now.
So we talk a lot about implants. So what I did is I ran and grabbed 3 implants that are all right about 300 cc's.
You didn't grab it. It magically appeared.
Magically appeared. So I'm gonna slide the screen over.
We've never done this. No. This makes me very uncomfortable.
So this is what I do with patients.
You
when
have to watch the
in.
YouTube channel. I'm sitting here very uncomfortable. She moved everything.
So this is a 310.
I'm gonna put it right up here.
This is a 310. Okay. So these 2 implants are the exact same cc size. Try not to make Nils' expensive computer fall off. If it was the Chromebook, I wouldn't care. So these implants are exactly the same size. They are both 310 cc's, but as you can see, they are totally different implants.
So this one has a very wide base, the one that's not as projecting, and the one that is more projecting has a very narrow base. What is the difference on these bases? Probably a couple centimeters.
Oh, for sure.
Yeah.
And then let's really confuse matters by putting this 350, right? So these are actually 310s, I should say. They were, to be precise, these are 310
That weirds
cc's.
me out because the 310 looks bigger than the 350,
Correct.
the one with the narrow base.
Right? But really, I mean, if you look at these 2 implants, these 2 implants, a 310 and a 350 have the exact same projection, but very different bases. You know, if you hold them this way, you can kind of see that, like this one's taller. So these project the same. This one is the same amount of cc's as this one, but it has no projection at all.
You're blowing my mind,
right?
man.
So,
stop it.
So let's just assume, Nelly
That's
girl.
like an MC Escher kind of looking at it.
It is. It's like the fork. Is that how many times are on the fork? Let's assume that you have this is a moderate projection implant. This is a 310. So this is probably similar to what you have. This implant is a 425. Okay, has basically the exact same diameter at the base, but look how much more it projects.
Yeah.
So it projects almost the same as this little guy, the 310, right? Same amount of projection. So if you have the 310, going up to a 425 isn't going to change the projection of your implant at all. All it's going to do is add width. Whereas if you have the 310 that's this one, it's not going to change the width at all.
It's going to change the projection.
It's only going to change the projection.
Yeah, so interesting.
So this is why you see that 420, I mean, going up, I think you need to go up to at least a 450, which you can do keeping the exact same diameter, just increasing the projection.
And the diameter matters because the pocket's already been established by the surgeon. And so you think about it, you probably don't want to go wider. Probably that implant fits you. So your only choice is to have a more projecting implant, which will look a little more augmented if you're of normal weight or lower weight.
But yeah, but it also might not, and it kind of seems like you would like a little bit more to balance out your hips. So you probably need the projection. Now, if you have, if like Dr. Martin said, if you have this implant that's very narrow, to go up to an implant that's very, very wide, you'd have to re-dissect the pocket a little. But just to go from these two, right? By
the way, it's very hard to go from a wider implant to a narrower implant. And that's where you get into grafts and doing pocket work, which is definitely more expensive and more involved. Yeah, I've never seen you do that. That's actually really interesting.
That's what I do with every patient who comes in for breast augmentation with us. So the myth, we do say that on our episode about implant selection, is that everybody wishes they'd gone bigger. That's not true. It's not if you're sized correctly in the beginning. And that's why expectation is key. If someone is saying to me, and there have absolutely been times where I've pushed a patient to an implant that they're like, this is way too big. A month and a half after surgery, they're like, and I say, how do you feel about your implant size? It's perfect. I'm so glad you pushed me to that because that comes with understanding the base, right? These 2 implants. If someone's like, oh, I don't want to be anything bigger than 300, but you see that this is going to basically look the same on 2 different people.
Yeah.
A 425 and a 310 is going to look exactly the same on a very petite person and a moderately sized person, even though they're different sized implants.
Yeah.
You get the same amount of projection.
Yeah.
It's just which fits.
Yeah. And I think that that's really important. Also, when we say we push people bigger, it's only 10% bigger. So it's the reverse of what we said before. When we get people ranges, it's usually pretty close to each other. So we're not saying, hey, you could do a 275 or a 450.
No, but there are patients who come in like, well, my friend has 300s and they look great on her. I'm like, right. And your friend this is your friend. Your friend is 310, right? To look like your friend, you have to do 425.
Every time I see implants samples, I think about a time that the patient came in and I handed it to her so she could feel it, and she handed it to her 2-year-old, and he started playing with it like it was a doll.
Yeah,
and I was like, this is so inappropriate.
Well, this is honestly a lot of the time, this is what my desk looks like.
Yeah.
Has implants all
we
over.
have a weird job.
Yeah, I got a
very
weird job. Like my job is weird.
Yeah.
So, and this is one more point, and then I'll be done with the implants. So 350, 425. This is the 75 cc difference that you think would make a difference. You see how it makes none.
Hopefully they can see that at
like,
home. Yeah.
Literally no difference. These implants project about, I think, 1/10 of a centimeter different.
Yeah.
The only difference between the two is a little bit of width.
That's crazy.
So to just size up in the same profile of implant, 75 cc's, you would literally, on most people, unless you were extremely petite, you would never notice the difference in 75 cc's. You just wouldn't.
Yeah.
So awesome question, Nelly girl. Good luck with your implant exchange.
Let's move this computer over. You're making me nervous here. Okay.
Throw my implants off to the side.
Yeah, I know.
All right. So we're back. So the thing
you did look young.
I did. Yes. So the thing here is measurements matter more than anything, and they matter a lot more than your friends or your sisters or your boyfriend's sister's implant size. People love telling me what everybody they know has the other implant sizes are. Doesn't, I mean, but you might be tall, you might be short. One day, I talk about this all the time. 4 breast dogs in one day. 3 of these women got the same size implant and they could not have looked more different.
And they all had different body types.
Different body types, different heights. They were different breast sizes at the end. So, one was a very, very full double D. One was barely a C with that exact same implant, because the amount of breast tissue you have is going to play a big part in how big your breasts are in the end, in addition to the volume that you add.
My favorite was the identical twins.
Oh yeah, they got different implants.
They got different implants, and we didn't obviously see them together. We treat them like them as singular patients, and they selected after our education different implants, which I felt was awesome.
They had different goals,
and it kind of fit their personalities a little bit. So
yeah. So within that base width, like I talked about in the video, then there's that volume and projection. And as Dr. Martin said, I really feel like, man, we're in a great spot right now with implant selection. Like I go back and think like when we had like 3 to choose from, and now we have so many and different manufacturers, and it makes it so much easier for us to look at a patient. We take that base measurement. On average for most women, this is a woman with like, let's say normal amount of breast tissue. These are the most ridiculous terms ever, but about 200 to 250 cc's is going to be a cup size in most women. So, we get that idea, what current size you are, what your kind of goal is. We look at pictures. A patient last week who sent me pictures, and I went in. So I'm like, I looked at these pictures, and she was in with our medical assistant. Our medical assistant came and got me and said, well, she's tried on this one. I'm like, did you see the picture she sent? Because the picture she sent was of at least a 500 cc implant. So I go in and I'm like, that picture you sent me is like a 500 cc implant. She's like, oh yeah, I don't mean how big it is. I just meant the shape. I'm like, so just normal breast shape? Like you just want your breasts to look like normal breasts. I mean, it was like it was just the most like, the difference there, I was like, it
find
was so
pictures
different.
that people send in fascinating.
They are, but and that's just it. You have to dig deeper. Like, why are you sending me this picture?
Right.
I've had people send me pictures of someone wearing like a push-up bra, and they're like, well, I want them to look like that. I'm like, well, they'll look like that in that bra.
Yeah.
Not without that bra on.
So the funny thing about these like pictures, which I do look at.
Yeah, and it is helpful.
Yeah, it is helpful.
Yeah.
Is that like, so people come in and you get a read from them what type of person they are and maybe like what their lifestyle is and stuff like that. And a lot of times they'll be just totally normal people and, go to church. And
how do you know they're normal?
Well, exactly. Have families.
Church going people in my mind are not normal.
Right. Well, okay. Well, I think they are. And then, but the funny thing is they'll send in pictures that are like these kind of almost pornographic level pictures. And I think the reason is when you go on the internet, it's hard to find pictures of breast without getting those types of pictures showing up. So they're just trying to show it to you in terms of size or shape and stuff like that.
Well, that's why I'll often ask people, I don't want to see pictures of breasts. Like, whose shape do you like? That's what helps more.
You mean body shape.
Correct.
Yeah,
and we've had some of the best ones when people will say like, well, I loved in the yellow bikini, Goldie Hawn's daughter. Who was that? Kate Hudson. They're like, Kate Hudson in the yellow bikini. I'm like, oh my gosh, I know exactly that, because it's like an iconic picture of her on the beach. I'm like, okay, perfect. We had a patient recently who said Kylie Jenner. I'm like, done. Like, I know what she looks like. So those things are helpful. And that's where I think, because people go online, they try and look up pictures of breasts, they're looking for pictures of like naked breasts, which is not really all that helpful.
Exactly.
Like, it's more helpful to see the contour.
I mean, it's helpful for a patient when they're naked, but most people are looking at their breasts clothed of some sort. Which
is why when people come in for pre-op, we always instruct them to bring a tight shirt.
Yep.
Because when you look at yourself, like with an implant inside a surgical bra, like you kind of look down and you're like, okay, like you don't really understand how you look. But when you put on like a tight tank top, well, then you're like, oh yeah, like now you see what the shape looks like how you look. And It's so much more helpful. And that's why, people ask if we do like the 3D imaging and stuff like that.
I was just about to ask you that.
Yeah, it's not that helpful because you're not seeing yourself. So what I'll do is I'll have people put the shirt on and I'll say, take a couple pictures, or the person with them, I'm like, take some pictures, because you're used to looking at yourself how you look. So when you look at a picture of yourself, with the tight shirt on with the implant, you're like, oh yeah, like I get it. Like this is right. Versus looking at yourself on an avatar, it doesn't mean the same thing.
Right. I totally agree.
Yeah.
It is funny because people use 3D imaging as like a big marketing tool. And I'm not against it, but I just don't think it's all, and also you're depending on, computer programming to somehow simulate what it's going to be like. And I just don't trust it. Now,
it could be deceiving.
If you had AI doing it and they could source, 10,000 pictures and somehow, and I'm sure this will come along. I mean, there's probably companies that are developing this, that they could source 10,000 before and after pictures, really analyze people's body types, do a 3-dimensional scan, and put all that data in for sure. But up to this point, the systems that are in these people's offices are not AI. They're at the most soft AI. They're not. They're like Apple AI. They're AI. So
even if it was perfect, you're still looking at then a flat, or even if you could put it as a hologram, right? And you could see yourself as this hologram.
Now we're getting some Star Wars stuff.
Yeah, which will happen. Well, actually, look at like when they do video games, they put those suits on people and they measure everything. There's still something about having that having your own clothes on so you can look at yourself and you can take it out and see the difference. Like that's what a lot of people do after we've kind of picked a size, like now take that out.
Right.
And now look at the difference.
There is something about self-perception and seeing something that feels and looks human, where like we've all seen CGI movies, even recent ones, that you can tell it's still CGI. It looks really good. It's really exciting, but you can tell,
Yeah, absolutely. And as someone who's done video and photography for over 30 years now, it's just not the same. Like no matter, someone can come in and they look great and, not the camera adding 10 pounds. It just does because it flattens you. And there's just nothing around that. If you're looking at a 2D image of yourself, it's never going to look like you do in real life.
Completely.
And it's just one of those things that people get really uncomfortable because they don't realize it. Like they dressed up nice. You got them on film. They did great. And then they see the footage and like, oh my gosh, I don't like how I look. And like, because you're not looking into a mirror.
Feel self-conscious, Dr.
No.
You guys are used to it now, but yeah, it's a thing.
Can it add 10 pounds of muscle?
That's what I want.
I know. Like
we both want 10 pounds of muscle.
Can we get 10 pounds of muscle?
Unfortunately, only adds
give me a
weight
facelift,
in the
Nils?
bad
Can
areas.
you make my biceps look really big?
Sure.
Here, let's just lift it up. There you go.
No, that's just skin. That's even worse.
So Amy bought me an Insta360 camera, which basically
you're gonna take that on your trip, right?
Yeah, I think so.
With all that, with that cool selfie handle thing. Yeah.
So and it basically maps it 3-dimensionally. So I think that you could figure out something like that in an office, and really truly map something 3-dimensionally.
Yeah. It's really just about viewing it. If you're not viewing it in 3 dimensions,
well, no, that's what I'm saying. You would have to view it, and that's the problem with the Insta360 camera itself, because you would have to view it in a headset.
Yeah, and which is really cool. I've done that where I've been on a site and shot 360 and then put it into my VR, put it on, and was like, I'm back. Like I'm right back where I was. You look all the way around.
So, but here's the problem with that. So a high majority of people get like nystagmus and like vertigo kind of symptoms.
Yeah, a lot of people can't do it.
They cannot do it.
Yeah.
And so you have a patient that comes in super excited about their breast augmentation, and like you put this headset on them, and then they're on the floor, nauseous, like with vertigo.
Yep.
Well, and the thing is, when you put the implants in the sizing bra, like you can feel it too. Which and I'll even have like if a person has brought their romantic partner with them, I'll be like, feel it, like because there might be the way that you kind of like feel like that matters too, and that's something you can't see on a 3D image.
Yeah.
So that's the implant sizing, not to try and make it seem like more important than it is, but like it's also not as complicated as it might seem.
Yeah, for you, other people can't seem to get it. So again, you should just do a course on implant selection.
That's
like graduating fellows in plastic surgery.
You got to hack inside my brain.
Yeah.
There are times I even surprise myself sometimes, especially because, when I'll see a picture of somebody who I've not seen in person, occasionally this will happen, or someone we've only done video with. So we've only seen them on video, and you still can just kind of nail it.
100% there's could be an AI assistant that does some of these things.
Yeah. The
Okay.
AI is coming for us all. Well, Catherine and I talked about that today.
No, not robots. Robots not yet. I'm going to be sticking around. You guys will be gone. Nils will be gone. I'll be sitting here by myself. Yeah. Still operating with other robots.
With other robots. Awesome. Well, I mean, I'd say I wish I could be there to see it, but you said I was dead, so so I won't be.
Well, when they take over, they're going to need me.
They will, because you're a doctor.
To operate on their energy sources.
Exactly, and they won't need me because implants will be gone. All right, so let's talk about the risks and complications, and then we're going to talk about surgery. Because we talked a lot about the major risks in part one, or the major bizarre things that could happen, most of these things are just risks of any surgery. So things like risks of anesthesia, bleeding, infection, the need for additional surgery, DVTs, cardiac and pulmonary complications, all those things are risks of any surgery. Changes in skin and nipple and areola sensation or numbness. Now, these are things that are unique to this surgery and could be persistent. So also you could have pain that may persist. When Dr. Martin talks about the surgical part of things, we'll kind of talk about why that might be the case in some cases. Bruising and swelling, poor wound healing, infection, hematoma. We have had this happen a couple of times, that you can have a bleeding episode after surgery. Usually it happens pretty quickly after surgery, like within the same 24 hours. But we did have that patient the one who worked at the bar, who had the hematoma that developed like a week after surgery.
I had a patient 3 weeks afterwards. Yeah.
So it can happen. And that's why it's important that you follow your post-op instructions. But even if you do, like, things can happen. And this is, just because it's elective surgery doesn't mean it's still not surgery, and doesn't mean that all of these things are not risks, because they are. So rippling and wrinkling, having a suboptimal aesthetic result, like, that can happen. Like,
for sure.
These things can happen. And some of this can happen because of the surgical technique that's chosen. And we'll talk about that when we get back from the break and talk about surgery. So asymmetries, all those things. But just know that just because this is elective doesn't mean it's not surgery, and doesn't mean there aren't still like real surgical risks in addition to the risks that we talked about in part one. Yeah. Okay. So we're going to take a break. And then when we get back, it's all you. We're going to talk about surgery.
I've been waiting for an episode and a half for this.
Yes, you have. Your time is coming.
Finally.
And we're back. Dr. Martin, the time is upon us. We are going to talk about breast augmentation surgery, step by step, easy for me to say. So I'm just going to say step one is anesthesia. You're going to have some anesthesia. You're going to be asleep-ish,
right?
At least.
In most cases, it's general anesthesia, but you can do IV sedation. We're not going to get into the weeds on that.
No.
One side point on this, sometimes people do blocks, regional blocks. They can do blocks within between the ribs or from your back. They can also do something called a PEX 1 and 2 block. And it really depends on the place you're going. We don't always do the blocks. Blocks have risk too. Mm-hmm. But if people request it, we have the capability of doing it. Yeah. And we do talk about it with people beforehand.
Yeah, and even just using like some Exparel, something that's not quite as involved.
Right. Exparel is local anesthesia that lasts longer than regular local anesthesia, up to 2 to 3 days. So
it's almost like a mixed blessing, though, because it wears off eventually. And sometimes it's better to just have the hurt right away.
Yeah.
Because when you've been feeling really good for 2 days and then people call me in a panic, like, it all of a sudden started hurting. I'm like, yeah, your block wore off.
That absolutely happened with my hernia repair. And I think I told you that. And I was like, I'm a very knowledgeable physician, but I'm sitting there.
Well, you wanted to come into the office the day after.
I felt great.
And I was like, absolutely not.
Yeah. And then by day 2, it felt like someone had dropped a small missile into my groin and like ignited it. And it was so funny because I was this close. I know the surgeon, he operates with us all the time. I was going to text him. I was like, oh, this is the Exparel wearing off.
If you want to hear more about that, when doctors need surgery, or when surgeons need surgery, was an episode.
I think it's when doctors need doctors.
When doctors need doctors. Yeah. There you go. Yep. When doctors need doctors. And Dr. Mark talks about his.
It's actually a pretty good episode.
It is. It's a good episode.
Kind of engaging.
Yeah. All right.
So that's anesthesia. So you'll go to the operative facility. It'd be an ASC, freestanding, a hospital, a doctor's office. You'll get pre-opt. When you're there, you'll meet the anesthesiologist. We'll mark you. And the incisions, is step 2, there's 3 different ones we use. Inframammary along the fold, at the base of the breast, and the armpit, and around the areola. We personally like to use the base of the breast. It's the best access to the muscle. We'd like to go underneath the muscle.
And it's the most hidden.
It is the most hidden. No matter what you think, when you're standing looking in the mirror, that is the most hidden. The one around the areola, if it doesn't scar right, you're going to stare at it the whole time. Yeah. In the armpit, with summer clothing for women, you lift your arm up in the air, you can see a scar there, and people are like, why do you have scars on both your armpits? So I personally like the base of the breast one, but we do every different type. So you'll mark that, they'll bring you back, set you on the operative table, and they'll put you to sleep, which is always a weird scenario, going to sleep. because you don't really remember going to sleep, but you do kind of remember bits and pieces of going back. But you do go to sleep, and at that point, we prep and drape you, and then we start the surgery. So we do inject local and make our incision. The incisions for these, no matter what approach, are like 2.5 centimeters, which is like an inch. So they're really small incisions, and you dissect down. In most,
if you're using a really big implant, it might be slightly larger.
Yeah, it might be larger. Yeah, over 550 cc's. Yeah. And then you dissect down to the muscle attachments. If you're going underneath the muscle, and you divide those from the 4 to 6 o'clock position, that's what we do. So that's going submuscular. Amy, let's quickly talk about the difference between submuscular and pre-pec.
Yeah, so that's in step 3. So we're either going submuscular, so under the muscle, or partially, which is I think a lot of what we do nowadays, which is kind of the newer way to do it, or directly behind the breast tissue. And in part 1, we talked about, why there might be some additional complications if you go directly behind the breast tissue on potentially breastfeeding or other things.
Nipple sensation.
Yeah, just implant show can be a lot more notable. So depending on how much native breast tissue you have, your doctor may or may not say you're even a candidate for a subglandular
because even partial coverage from the implant will cause compression on the implant and decrease the visible rippling. Mm-hmm. And then also it'll have a more natural upper pull just because the compression of the muscle. You don't have this chest wall and then all of a sudden this jutting out implant.
Yeah. Typically the only time that we do the subglandular is if somebody already has it and for whatever reason doesn't want to change the plane. Mm-hmm. Or they are like a competitive bodybuilder or someone who absolutely depends on the ability to use their pecs in a very dynamic way. Because in those cases, and it's so funny when people will come in and they'll push their hands together and flex really hard and be like, see, when I do this, I can see the implant. I'm like, yeah, you'll always be able to do that.
Right. That's called a window shading.
Yeah. So I said, when are you doing that naked in front of people? Probably never. So
hold on for a second. Let me show you something before we get busy here.
Exactly.
Yeah.
It's so
I know,
funny.
But still, it's annoying. It would annoy me.
It wouldn't annoy me because when are you doing that? Like that's more of I don't know.
Yeah. If you have, this is a side point, but if you have tuberous breast, in that situation, you would do a periareolar or mastopexy or around the areola mastopexy, and then also a subglandular augmentation, which we, in many cases, will do a subfascial augmentation. So we put the implant underneath the fascia over the muscle, but not underneath the muscle. So it's
gives a little more coverage.
Gets in the weeds, But most cases, I think fairly standard SOP in the industry is underneath the muscle. Mm-hmm. I do think more subglandulars are going on. It's just person dependent. And this another side point, actually subglandular or above the muscle is the way primarily we do breast reconstruction now. So we should do a breast reconstruction episode at some point in the future, in the near future. All right, so you go underneath the muscle and you elevate this pocket, or you form a pocket where you can put the implant. And this is a big part of it. So if you get some surgeon who doesn't care, who has bad technique and develops a pocket that's super wide and it's not like a perfect fit for the implant, that's when the implants tend to slide to the side. They don't look right. After surgery, one implant's higher than the other. It just doesn't look right. And so I think that this is where technique really does make a difference.
Yeah, the precise handling of the pocket. And this is also, where really the bulk of the pain comes from after the surgery too, is because you have, moved that muscle around. And that is a reason why some doctors will push the, subglandular, because there's less pain.
Definitely less pain.
There is, but also, there's downsides to that. But I think they also maybe just don't want to be as delicate, because that pocket really does make a big difference in the outcome.
Right. I think if you go submuscular, you can decrease the pain and increase the time, or decrease the time of recovery by using really good technique and not being forceful, just really kind of being elegant with your surgical maneuvers. Again, we want to make it really clear, in our world, breast augmentation is not a complicated procedure. So we're not going to sit there and give you all these dazzling words and superlatives. It's just not that way. But there is technical issues or technical points of the surgery that make it better. So that's why you got to go to someone who does these on a regular basis.
Yeah, and who cares?
Right. So then you'll kind of get some hemostasis after you elevate that pocket. That's super important. Mm-hmm. If you don't get adequate hemostasis and there's blood around the pocket, that will increase the chance for postoperative scar formation, which is called capsular contracture, which we'll talk about afterwards. You put the implant in there, and a lot of people will use sizers and all these different implants. Amy and I are pretty dialed in on the implant size, so we don't often have to use sizers.
Rare. Especially with a breast aug, maybe with a lift.
Maybe with a lift. Yeah. Sometimes we'll do it when there's a notable asymmetry.
Yeah.
And then in most cases now, people soak the implant in an antibiotic solution, or a half saline, half betadine solution. And why is that, Amy? What is that theoretically doing?
Getting rid of the biofilm.
Right. So this idea of a biofilm around the implant, which is the biofilm we believe leads to capsular contracture.
Or could trigger it.
When we did the last episode 100 years ago, apparently, even though I think it was yesterday, we still didn't totally know why capsular contracture occurs. We still don't know, no matter what anyone tells you. But we have found that using triple antibiotic solution or half betadine and half saline does make a difference.
And the Keller funnel.
We also use a funnel, which we joked that was like the
horn of plenty.
No.
Yes.
Not the horn of plenty.
Yeah,
that is a good one.
The cornucopia.
The cornucopia, but no, like for pastry. Like a pastry bag.
Yeah.
Yeah, it's the idea of a pastry bag and you push it through, but it doesn't touch the external skin. No matter how much you sterilize external skin, you're not going to get rid of all the bacteria that's there. Bacteria is healthy on your skin. It serves a purpose.
Yeah, it's part of your skin microbiome.
Once that gets drawn in around the implant, that could create a smoldering biofilm inflammatory situation that could lead to a capsule. And in rare cases, ALCL and all the stuff we talked about before.
Well, and the nipple in of itself is a two-way street. Things can come out of it, but things can also get in it. It has tiny little holes.
So historically, that's why you don't want to do subglandular because it increases the chance of capsular contracture. I think some of that data is being refuted, but in general, that's why we like to go underneath the muscle too. Is historically speaking, the data showed less capsular contracture or scar formation. And the idea was that putting an implant underneath the nipple and areola and the ductal stuff does contaminate it somewhat. Yep. I'm not sure I believe that, but you know what I'm saying. But
it's a theory. I mean, it's
the way we were taught.
Yeah,
that's the way we were taught.
It's as much a theory as the biofilm
Literally, theory. That was a question on this year's in-service.
Yeah.
So, once the implant's in place, we sit you up, we look at everything, sit you down, close it. It's usually a couple layers, and again, the incision's only an inch, and wrap you up. Most people wrap you up with some ACE wrap or something that's a little bit more compressive.
Yeah, for that first night. And that can be pretty uncomfortable because you swell after surgery ends. So even if you're wrapped, let's say snugly at the end of surgery, by the next morning when the swelling has all hit, like that snug wrap is now extremely tight.
Yeah, totally.
So yeah, you're more than ready the next day to see your doctor and get to take that wrap off. Yeah. All right. So that's it. That's the surgery in a nutshell.
Yeah, and that takes me 45 minutes.
Yeah, it is. It's a quick surgery.
I'm going to say a few superlatives of how special I do it, and I'm a unicorn in the woods. No, I'm not going to do that.
I mean, if you're going to be if you were a unicorn, you really want to hide out in the woods?
I don't know. I feel like unicorns stay in the woods. Why, if they did, you don't see unicorns walking down the middle of an urban street.
But you should. I mean, if I was a unicorn, that's where I'd be strutting, right? Yeah.
But it is it's a really cool surgery. It has some elegance to it. I think the pocket development. Some of the techniques about getting hemostasis and doing it correctly.
Yeah, and gently.
And it's also a very efficient surgery if you do it all the time. So, I mean, I could probably do a breast augmentation in 25 minutes by both sides. I slow down on purpose. I make myself slow down, but that's how quick you can do this surgery. And then think about that though. If you're looking at doing the surgery and you realize that it's a very quick surgery. They charge you X amount of money. Think about the surgeon that does these all the time. They can monetize it, right? So it's a quick surgery. You can do 2 rooms. You can do multiple cases in a day. So you really want to go to someone that is efficient like I am, but also is not trying to rush through it and do 12 cases a day.
Right. Like an ortho. This isn't like a total knee.
Yeah.
Yeah. All right. So you've had surgery. Your unicorn doctor has gone back to hide out in his his unicorn village in the wood.
Cornucopia horn.
It really does. It looks like the horn of plenty.
Yeah.
So now you have to recover. And to me, I think a real key with recovery is to prepare for recovery, because if you're prepared, it's going to go a whole lot easier. Make sure you read your your post-op instructions and review those with your primary caretaker. The thing that we put on our post-op instructions is all the things you can expect and then when to call. And those when to call are the things that you want to make sure your post-op or your care person knows, because depending on the caretaker, like if you if you go like that, they're gonna be like, oh my gosh, like I gotta call the doctor. Like, no, you're fine. But you're kind of out of it. So like, you're fine, but your caretaker might not. So make sure you share those with them as well so that they're not worried unnecessarily. You should know when and where your first post-op appointment will be. With us, a lot of times now, our first post-op appointment with the patient is via video so that they don't have to leave their home and ride in the car, because that first car ride is not comfortable the day after surgery. Mm-hmm. Fill your prescriptions. Definitely fill your prescriptions. Purchase any recommended post-op products, garments, ice packs, etc. The pillow system is linked in the description box below because it does help. You do have to sleep on your back after this surgery, and you do want to be at a slight incline, which is going to help with swelling and just kind of positionally. It's going to be really helpful to have this pillow system. I also recommend the Squishmallow, especially after this surgery, because it just kind of helps you feel like your head is able to rest a little bit and just be a little more comfortable, and it keeps pressure off your chest. Think about the things you use on a daily basis and move those items as close to waist level as possible. Everybody knows the T-Rex, right? We tell them the T-Rex after surgery, right? Like T-Rex can't lift this. What people don't think about is having to bend over, because when you bend over after this surgery, it can feel really weird.
Also, the T-Rex, when you're bending over,
you can't go very far.
You can't go very far.
No, you have to like squat all the way down.
I was just thinking about that, like kind of keeping your elbow. You almost have to squat, yeah,
which
can be hard, especially for people that have knee or hip issues. So.
Yeah, so just moving things, like I said, as close to waist level as possible is going to be very helpful, especially like in the shower, like not having to reach up or reach down for things is going to be really helpful. Plan on at least a few days of loose, button up, easy to put on clothes and slip on shoes. Because again, bending over, like how would a T-Rex tie his shoes? He can't. T-Rex cannot tie his shoes. Yeah. So slip on shoes and just easy stuff, you know.
I feel like you're kind of T-Rex shaming. I mean,
hey, T-Rex also can't do push-ups.
Yeah.
Right. It's not my fault the T-Rex.
Yeah, but T-Rex was like 5 stories tall.
Well, the T-Rex will just eat you in one big bite. Off, right. Yeah. I mean, there's a lot of things a T-Rex can do. He doesn't care if he can't tie his shoes.
The great white doesn't care. It doesn't have shoes. It's just going to kill you very easily.
That's right. Right? You think a shark cares about that? No, a shark just is out there being a shark.
Yeah. Shark be shark.
That's right. So those are, things, because you aren't going to be able to lift your arms up over your head. Again, a T-Rex can't put its arms up over his head. So stuff that you can slide into, hoodies, zip up things, like just plan on some loose, easy to put on clothes. And it is normal to be nervous and excited.
Yeah.
Still surgery.
Yeah.
And there's still a little bit of an unknown. I mean, even though we talk so much about the implant selection, trying them on and getting to feel them and all those things, like you still don't really know. It's not like a facelift where you know you're going to look like you did.
Well, I mean, after a breast aug, you definitely see a change right away, but then you're swollen and almost Frankenstein-y a little bit.
And they're sitting like right at your collarbone.
So they feel high. So then there's a transition period where you have to trust the process.
Yeah.
So when anyone says to me, trust the process, I don't trust the process, just so you know. So
you are the process.
But I am the process. But it does. 3 to 4 weeks before you really start seeing that swelling go down.
Yeah. Yeah. And we'll talk about the week by week too, because initially, breast swelling and pain, right? But the thing that hurts more than that is your back. Like people will tell me like my breasts feel fine, my back is killing me, because you do this after surgery. You hunch your shoulders forward and you're like, it's natural to want to protect yourself, but it's like, because your muscle is really tight, you don't want to let your pec relax. So I always tell people, like, let your shoulders drop.
Yeah, you can do it. Don't let your back into it, right?
Don't let your back into it. And like, that's take your muscle relaxants if your doctor provides them for you, because it's really going to help with some of the stuff that isn't really because of the surgery. It's because of the surgery, like it's not the surgery itself that hurts. It's all these things around it. Some bruising is very patient dependent. Most patients probably won't have any, but it's not abnormal to have some. Temporary changes in the skin sensation and nipple and areola sensation.
So it could be hypersensitive or hyposensitive.
Yeah. And that skin can feel so sensitive to the touch. Like it could be like, just like make it feel like your skin is crawling. It's so sensitive. Or it might just, like I said, be kind of numb. You definitely, the first week, you're going to have limited use of your arms. You're going to have lifting restriction, probably 8 pounds, about a gallon of milk. You can walk as much as you want, and walking is really good. You probably take pain medication for a couple of days before switching to Tylenol. Most of our patients, about day 2, 3, are like totally done with the pain meds. They're just taking Tylenol. Because it's not, as long as you're not doing anything to like hurt them, they're going to be,
Yeah, we've had patients take it for a week, but that never longer than 7 or 10 days.
No. I can't even say longer than 7.
Yeah, I think 7 days.
If a patient came in at 7 days and said they were still reliant on it, I would be like, we got to talk.
Yeah, we got to talk.
Yeah, we got to talk.
We've had a few of those.
Yeah, and we got to talk.
Yeah, we have to have a conversation.
Yeah. The muscle relaxants, though,
could go on for weeks.
Yeah.
If it's necessary.
Yeah, because that can't really help. You're going to be wearing a soft, stretchy, non-underwire support bra for at least, for us, about 4 weeks, but you can plan at least a couple weeks of wearing non-underwire, soft, stretchy bras.
Zip in front usually,
Makes it so much easier. So that you can either zip it into or step into, because again, T-Rex can't hook a bra. You can return to most work and driving as long as you're off pain medication at about a week. And I say most work because if you're doing something that requires you to lift, obviously not. But if you do desk work or work from home, like those are things you can return to pretty quickly.
If you produce podcasts, things like that, you can do it in about a week.
Yeah. Weeks 2 and 3, I say your world gets a little bigger. You can have more use of your arms, a little bit of an increase of range of motion. You're feeling much better in most cases. You're still wearing your stretchy bra, and you can return to some exercise. Obviously, nothing that's direct chest. Chest, arms, even things like that a lot of people don't think about that I tell them like, oh yeah, like no, like tricep push downs, like all the things you don't think engage your chest. But remember that pec muscle attaches to your arm.
So any abduction, when you take your elbow and move it away from your chest, all that is going to hurt.
Yeah.
It's going to really put stress in the area of surgery.
Yep. Or anything where your arms are fully extended overhead, like pull downs or pull ups. Like, oh gosh, I remember a woman asked me if she could dead hang from the bar.
What about triceps push down with your elbows at your side?
Well, yeah, that's where you use the bar instead of the rope.
Yeah, I'm talking about the bar. That's what
or single arm, where you could really make sure that you were isolating that humeral movement, because it's moving of the humeral head that starts to hurt. Yeah. We clearly work out. so yeah. At 4 to 6 weeks, that's when you're going to be cleared to return to most exercise. People, around 6 weeks will ask me if they can start like jogging or running, those things that are more impactful. And typically at that point, as long as it's not causing them discomfort, it's okay. But again, follow your own surgeon's recommendations. You might be able to switch out to a non-underwire bra, maybe start using a topical scar cream, although in most cases it's not necessary, because we have the unicorn surgeon here. I mean, it really isn't, but if you can, if you choose to. And then week 7 and beyond, like I always say, the leash is long now. You resumed all your normal activity, no bra, which is, we have patients who literally when they come in, like that's their goal. Like, I don't want to wear a bra. I want my breast to stay like this with no bra. Like, got you.
I think the most important thing is to love your results.
Yeah. And that usually starts from day 1.
Yeah, but just to really enjoy the fact that you've accomplished what you wanted to accomplish. They look better, the contour's better, the volume's better, you look better in clothes, you have more body balance. Or maybe you don't have body balance and that's what you wanted.
You wanted to be asymmetrical.
Whatever you wanted. Yeah. That's awesome. I mean, these patients are some of our happiest patients for sure.
Yeah, all of our patients are happy.
These are happy patients though. It's fun. It's instantaneous. You got this change. Yeah. The recovery period can be a little touch and go, but it's not terrible. I think when I first started this, I'm like, breast aug is so hard to recover from. Now, after almost 20 years of doing this, I don't think so. I think it's
have a thigh lift. That's hard to recover.
Yeah, I think it's in the middle.
Yeah,
of things we do. So
yeah, I mean, the great part is if you watch part 1, you see the age demographic. I mean, the biggest majority of people doing this surgery are under 40. So they're young, they're healthy. It's a pretty easy recovery for the most part.
And if you're a healthy patient, it makes it easier.
Yeah, absolutely. Yeah, loving your results is the big part of it.
Let's do it.
That's like the irony, the big part.
Okay.
You don't think? Oh no, man,
that's not irony.
Totally fell flat. I thought it was funny. I thought I was punny.
You're doing what's her name? But isn't it ironic? That wasn't ironic.
It wasn't ironic at all. Yeah.
This is bad luck. Alanis Morissette. Yeah. Like having rain on your wedding day.
That's lucky.
Like, that's just crappy. That's not irony.
It's luck.
It's bad luck.
Mm-hmm.
I think bad luck is a better way.
They tell you it's good luck because they don't want you to feel bad because it sucks.
Yeah. Oh my gosh. So you want to hear a really short story about a bad wedding experience? So when I was a kid, my mom was a professional cake decorator. So she had made this elaborate wedding cake for this wedding. It was like these 2 big sheet cakes that were decorated to look like a garden. So like, we're talking like tons of colors, and there were staircases. This was in the 90s, staircases that went up to this like top tier. But I mean, it was like, thousands and thousands of piped down flowers. Well, it poured rain, and it was an outdoor wedding. The cake was under a tent, but the tent, it was raining so hard that the tent was starting to sink. Well, so people were going around and pushing the water up. Well, so sure enough, they pushed it up, and not only did it splash up and like get all over the cake, it also like doused the bride in muddy water because the ground was dirt.
Yeah.
Yeah. So like my mom was like screaming, and like the bride is screaming, and like there's mud all over her, and the cake is wet.
I think that's when you have to embrace it at that point.
That's pretty much what happened. Yeah. Yep. That's what everybody did.
Have a backup spot would be I did,
right.
wedding videography in my past life for about 10 years. And yeah, it's not I don't recommend that gig, but man, just have a place to go inside if you need.
Or you put on Guns N' Roses and just
November Rain it. Yeah. That actually, we can tie that back to breast aug, because we do have patients who come in and, want to have a breast aug somewhat before their wedding. I would say at least 3 months.
Yeah.
For swelling to go down, and also for dress fittings. So if you are planning to do this surgery anytime around your wedding.
Because of the dress fitting, I would almost say 6 months. Because your swelling would go down, and then 3 months to get your dress. Now, that's historically experiencing that with my wife because this dress fitting thing seemed like way harder than it should be.
Well, because brides lose weight, so they're constantly having to adjust it.
Why is this so difficult? Why do we have to go to 12 different places? That kind of thing.
Because it's got to be perfect.
Okay.
Yeah. But if you are considering breast dog and you're getting married, or even if you're a bridesmaid, give it at least a few months.
We got married on the beach with Fiji with 4 people there. So I'm not really sure that it had to be perfect. I don't think.
But it was perfect.
Oh, it was perfect.
Yeah.
That was an amazing time. All right.
Yes. Well, you guys just celebrated a big wedding anniversary too.
Yeah. 20 years.
It's crazy.
Let's go.
Crazy. All right. Well, we thank you all for listening to the end. See, if you don't go all the way to the end of these episodes, you miss stuff like this. So yes, the banter, the fun stuff. But if you would like to leave us a voicemail or send me a text message, you can do that at 303-630-9038. I would also love it if you would share this video with someone you know who is considering breast augmentation, because we do hope that more than anything that our podcast is helpful.
Yeah.
So, Dr. Brent, you got any wrap-up?
No. I think we've checked every box for breast augmentation.
Well, what's coming up next is December, and in December we're going to do our top 5. So we got good things coming.
I got to start doing that.
Yep.
Not the day before like I usually do.
No. Nils says no, please no. Yeah.
Okay, all right.
All right. Well, we'll see you guys all here next time.
See you later.